Hello everyone. So this session is about fluorides. So fluoride topic comes under preventive dentistry chapter. So this is a very important chapter in which you'll have to learn about the systemic fluorides, topic fluorides, modes of fluoride application, and etc. So I'll move on to the topics. Like in this chapter, you will be learning about what is the history of fluorides, then modes of fluoride application. That is one of the basic question or the common question which you might get in your exams, then a little bit about systemic fluoride, which you have already learned in your public health or community dentistry. It is the same thing. Then topical fluorides, like commonly applied topical fluorides in the clinical practice. Then what is the self-applied fluoride? Then what is fluoride toxicity? And last but not the least, defluoridation. So fluorine is not found as a free element in the world or in the nature. So it is basically found as a compound along with calcium or sodium because it is highly electronegative. And the term fluorine is derived from a Latin word fluor, which means to flow, since it was used as a flux. It was basically used as a flux. So that is why it has got the um, name from the Latin word fluor, and finally it was termed as fluorine. So basically, the sources of fluoride comes to us by the means of toothpaste, which is enhanced with fluoride. Then fluoridated water supplies. Then there are mouth washes enhanced with fluoride. Then there is food processed with fluoridated water. Then fluoride supplements, etc. There are various sources of fluoride. So you have to know how this process or from where these fluorides have been started to add in our daily routine practices. Like why did they come up with the um, idea of toothpaste with fluoride and supplements, water supplies, etc. So it does definitely will have a basic history. So it was this column you will find it in Nikhil Marwa. So just whenever you get time, just go through it. But still, I'll brief it up for you. So all happened by somebody called as Dr. Frederick Mackay in 1901. So he's actually a person who lives in Colorado, USA, and he found out that there are like in that habit, like patients, in his patients in his clinic, there are many of them who have got this black brown stains, and it was commonly known as Colorado stains by the local inhabitants. So he, at this stage, failed to relate the stain with any factor. So he could not find it out from what it is or and why it has come. So he named it as mottled enamel. So initially, this fluorosis was dental fluorosis was initially named as mottled enamel. So finally, he collected all these cases and he presented in this as a case report in 1908 in an annual meeting of State Dental Association in Boulder. So from there, he understood that this lesion was not only found in Colorado, but it has been extended to other towns as well. So in 1912, Frederick Mackay came across an article. So there was an article published by Dr. J.M. Eager in 1902. He was a U.S. Marine Hospital surgeon, and he also had found out a similar kind of lesion, and he had named it as dentitiae. So um, it was reported that a high proportion of Italian residents in Naples had brown stains, and the features of these lesions was very much similar to that of what Dr. Frederick Mackay had found in Colorado. So in 1916, what he did was, it is something which is a very common. This lesion has become very common. Started finding this lesion in many places. So he and Dr. Black conducted a survey in 6,873 individuals in 26 communities. So it is not a small study. A large communal study was conducted, and during this time only, he found out there is some unknown factor, there is some element or something which is responsible, and they found out that it is from the domestic water. During the period of which tooth calcification may be the cause of mottled enamel. So they already found out that some element in the water is the causative factor for the formation of such a lesion. So in 1918, what he did was he observed that individuals reared up in Britain since 1898. So from 1898 onwards, whoever has born after 1898 had this lesion, whereas individuals who were lived or past their childhood before 1898 did not had these lesions. So that is how they concluded that there is something or some element which was um, a mysterious element which is present in the water supply, and that is the one which had been acting during the period of tooth calcification, and this is the one which is the reason for the formation of the mottling of the enamel or dentitiae or something called as the Colorado stains. So it was noticed that after 1898 there was a that place had changed its water supply from individual shallow wells to deep drilled artesian wells. So they changed the water supply during that period, and whoever had born after 1898 and who had passed their childhood through 1898 or after 1898 had these things. So in 1925, the inhabitants of Oakley, Idaho, were so much convinced by the water supply hypothesis. So this was actually true, and that they found out that after switching the water supply, only the children started having, or the individuals who are staying there had started having such black stains or brown stains on their teeth. So in 1931, what happened is a chemist, you will be familiar with this name, Churchill. He developed a method for determining concentration of fluoride in drinking water. So he was someone who was studying fluoride and its concentration in water. So he was very much eager to know about this, and he found out that this is fluoride is the element which is responsible for such a condition, and he found out that the concentration of fluoride, that is 13.7 ppm of fluoride in bauxite form, that is, in addition, the level of fluoride was very high in the water from other endemic areas for mortality. So he started collecting water from these places who have such a lesion, and he found out that fluoride is the culprit behind this ugly condition. So then it was all it was familiarized to many whoever was studying in this field, and there they introduced this element, the major reason for the formation of mottled enamel. So in 1934, Dean conducted the famous shoe leather survey. Shoe leather survey is something which is very important for you people. You might get short notes or short essays on shoe leather survey, and it was established that the concentration of fluoride in drinking water was directly correlated to the severity of the fluorosed enamel. So, as the concentration of fluoride increases, definitely the enamel is going to get fluorosed. So, Dean also developed a standard classification of mottling and an index to quantify it as mottling index. This is what you learn as Dean's fluorosis index, which was described or explained by Dr. Dean in 1934. So later it has been modified, the modified version you will be learning it. Then in 1939, to test the correlation of fluoride in water and dental caries, so several studies came out with the correlation of fluoride in water and its relation to dental caries, and a survey of 4 Illinois cities was planned by Dean. So again, Dean started conducting studies based on this correlationship, and he found out that the caries experience was found to be very less in areas where the fluoride concentration was around zero point 0.2 parts per million and was more than twice as higher. That is, in case if, like, as the fluoride concentration increases, the caries experience was found to be very less. And Dean finally concluded that he was the one who found out that 1 ppm fluoride in drinking water was actually a really good proportion to reduce the caries experience in the population or in the people. That is 60% was achieved, like sporadic instances of the mildest form of dental fluorosis of no practice. That means if the concentration was above 1 ppm, 1 parts per million of fluoride, and if it's more than that, then definitely the whoever is going to live or whoever is having uh, in if their teeth is in a maturation stage, or if they're in the developmental process, or if a child is growing in that area with increased fluoride concentration, he found out that they will be having like fluorosis, or enamel will be fluorosed, or they will be having a mottled enamel. So he was the one who found out that 1 ppm is the max, or the maximum reduction, or the max concentration of fluoride level which we can follow in drinking water. So in 1945, first community level water fluoridation program started in Grand Rapids, USA. I think you must have learned all these pioneer studies or pioneer water fluoridation places which has already taken place. And in 1950s, water fluoridation started in US in the states of Florida, Illinois, California, Ohio, and Missouri. And 1964, with the WHO and the Pan American Health Association endorsed the practice of water fluoridation. So that is how they found out the importance of fluoride, and what is the toxicity or toxic level, and what is the importance of defluoridation. Everything came into action once they found out that fluoride has got its own pros and cons. So this is the history of fluoride. So shoe leather survey, you might get a short note question, which I think you must have already learned this in your public health industry or community health industry. So this was actually what Dr. H. Trendley Dean did was he studied the relationship between fluoride concentration in drinking water, then the relationship of mottling of the enamel and plus the dental caries. So his aim was basically to find out the minimal threshold of fluoride. So minimal threshold of fluoride is a level at which fluorine began to blemish the teeth. He showed conclusively that the severity of the mottling increases with the increasing fluoride concentration in the drinking water. So beyond 1 ppm and all, he started noticing that there have been certain changes, or it is starting to cause severity. The severity of mottling increased as the uh, level or concentration of fluoride increased in the water or the drinking water. So after that, he observed, after doing that study, he gave the following observation that water concentration was 4 ppm or more. It showed signs of discrete pitting on the enamel surface. Water concentration above 3 ppm showed mottling was widespread, and water concentration to 2 to 3 ppm of fluoride. In that case, dull, chalky appearance. Water concentration was 1 ppm or less. Found that there is no mottling of any aesthetic significance. He also reported that the incidence of caries in these teeth was less as compared to the non-fluoridated teeth. So he was comparing it with fluoridated, like he only controlled these levels of fluoride in water, and he was comparing it with that of the non-fluoridated teeth also. Coming to modes of fluoride administration. Fluoride can be administered topically, whereas systemically. So systemic administration was the one which we had been discussing so far. That is by in water fluoridation technique. So in drinking water and all, we tried doing that. So that is what systemically we are ingesting the fluoride, and we are getting the results. Whereas topical is something which you can professionally apply onto the tooth, or it can be even applied like self-applied. So basically, the modes are topical and systemic. Topical can be professional, self-applied. So professionally applied fluorides are your neutral sodium fluoride, stannous fluoride, APF solution or gels, STF varnishes. Then the self-applied ones are there are dentifrices, nothing but a toothpaste, mouthwashes which is incorporated with fluorides are available. Then fluoride gels which are used as specifically for a self-applied version. Systemic can be water fluoridation, which includes your community water fluoridation, school water fluoridation. Then you have the milk fluoridation, salt fluoridation, and then there are the fluoride tablets, lozenges, drops. It all basically depends on the community level fluoride concentration. Then if there is any other programs stated, based on that only this will be endorsed in states and districts or in countries. Okay, then moving on to the mechanism of action. So, mechanism of action of fluoride is very important, and there are basically 5 points which you should mug up or by heart it. If you understand the meaning of this, it will be easier to grasp. So, there are these five major mechanism of action of fluoride onto the tooth. That is nothing but increases enamel resistance or reduction in enamel solubility, then increases rate of post-eruptive maturation, remineralization of incipient lesions, interference with plaque microorganism, modification in the tooth morphology. So we'll like discuss briefly on all these mechanism of action. So increase enamel reduction resistance or reduction of enamel solubility. So whenever there is an acid attack, so when the pH critical pH falls below 5, so there will be the atmosphere will change into an acidic environment. So if there is presence of fluoride, these acids will combine with the fluoride in the plaque. So fluoride can be present in your saliva, plaque, and in the oral environment if you're using it in if you are systemically injecting or if you're topically ingest like applying. So this presence of fluoride will definitely cause to certain reactions. That means it will penetrate at the subsurface and will form this hydroxyapatite crystals or whatever which is present onto the enamel surface. This will get changed or converted into fluorapatite crystals, which are highly insoluble. So when you compare with the normal hydroxyapatite crystals with the fluorapatite, you can see that the fluorapatite is something which is very stable and which will help to stabilize the which will reduce the dissolution capacity of the enamel. Then it will also absorb to the this fluoride whichever is present onto the surface absorbs to the crystal surface. Crystal surface is nothing but your enamel, then protects these crystals from dissolution. So from dissolution means it is basically by converting these hydroxyapatite crystals, which are the major component of the enamel, converting it then to a very stable component, which is nothing but your fluorapatite crystals. Then it also shows increased enamel resistance or a reduction in enamel solubility. It is basically by the conversion of this hydroxyapatite to fluorapatite crystals, and fluorapatite is found to be have less solubility. So when there is an acid attack or in the acidic environment, this fluorapatite does not get dissolved that in that kind of a critical time period. Then there is this increased rate of post-eruptive maturation. So there will be places like hypomineralized area, which is very common in the newly erupted teeth, which uh, which is very highly prone to dental caries. And if there is a presence of fluoride, it is found that there is increased rate of mineralization. So which we can relate it to the modification of the tooth morphology also if it is during the eruptive stage or if it is in the developmental stage. So post eruptive maturation and remineralization, and these are basically similar processes, but maturation occurs in a hypomineralized area where remineralization basically occurs in a demineralized area. So demineralized area means if the caries process or incipient caries is already started means there occurs the remineralization. Remineralization occurs even with the help of this also occurs with the help of fluoride by forming the stabilized component fluorapatite to fluor hydroxyapatite crystals. So, and in post-eruptive maturation phase, there occurs the maturation, or this is something which happens in hypomineralized area. Then remineralization of incipient caries. So here, remineralization of incipient caries is basically if there is demineralized areas, that means a plaque acid or if the acidic bacterial toxins or has entered into the enamel rods and that is how basically the teeth of or the enamel breaks down. So if that process is happening, that means there is a demineralization happening there. So once there is this presence of fluoride, what happens is this fluoride which is present in the saliva or if you are applied fluoride on top of it, this fluoride enters into the rod and the tooth, like it will enter into these enamel structures and will form a stable compound. So that is how it starts remineralizing the component. So enamel is basically remineralized after the addition of the fluoride. Then it has got other actions like interferes with the plaque microorganism. So it is fluoride is known to have bactericidal and bacteriostatic action. So in a high concentration, it has got a high bactericidal action, And in a low concentration, it has got fluoride has got the bacteriostatic actions. So it basically it has been shown that it interferes with the plaque microorganisms also. By inhibiting the enzymes like enolase, phosphatase, and it will inhibit the cation transportation. Then it has got the fifth, that is not last but not the least, modification in the tooth morphology. The fluoride which is ingested during the tooth development. So if you're ingesting the fluoride or systemically, if you're getting fluoride, and even if you're topically applying it, it is found to change. That is, developmental changes will happen. Like it will definitely have a shallow fissures, decreased diameter, like smaller cusps will be there. Like the more, the riskier anatomical features, like morphological changes, anatomically changes. Presence of fluoride will changes into a well uh, a good morphology which does not has any risky tooth surface area or a surface area which will cause caries in the future. So that is basically on the mechanism of action. So here this is another pictorial representation where the remineralization happens here. So it is nothing but basically in the demineralization process, the carbonated hydroxyapatite enamel crystal. This is something which is highly soluble. This form of hydroxyapatite crystals are highly soluble when there is an acidic pH, or in that condition, the demineralization occurs in the presence of an acid in plaque. So there the tooth becomes partially dissolved. So partially dissolved crystal will be formed over there. And in the presence of fluoride, if you apply a fluoride on in that area, or so the plaque will get incorporated in the plaque, sorry, fluoride will get incorporated in the plaque, and the fluoride, this presence of fluoride will help in the remineralization process by formation of fluorapatite like coating on the remineralized crystals, by that is basically by forming or converting this carbonated hydroxyapatite enamel crystals to a fluorapatite like crystal. So basically, it has these action rendering enamel more resistant to acid dissolution, then inhibition of bacterial enzyme system enzymatic action by reducing tendency of the enamel surface to absorb proteins, modification of the in the size and shape of the teeth. It enhances the process of remineralization. So there we conclude about the mechanism of action. So you should be learning more about mechanism of action. Please go through the mechanism of action. Just let me know if you have any doubts. Then coming to the most important, which cannot avoid, that is systemic fluoride. So community water fluoridation is defined as the upward adjustment of the concentration of fluoride ion in public water supply in such a way that the concentration of fluoride ion in the water may be consistently maintained at 1 part per million by weight. So it's basically fluoride concentration is being controlled and it is being upwardly adjusted. So if the fluoride is not if the presence of fluoride is none in a water supply, then we will upwardly adjust to 1 ppm such a way that this concentration, the increase in the concentration, consistently maintained and it will be supplied to the population over there. So the fluoride compounds which is basically used in water fluoridation are your fluorspar, sodium fluoride, silicofluoride, sodium silicofluoride, hydrofluorosilicic acid, then your ammonium silicofluoride. So water fluoridation is basically done with several systems. So it is being named a saturated system. It can be dry feeder system or solution feeder system. So the procedure of saturated system is what they do is 4% saturated solution of sodium fluoride is produced and injected at the desired concentration of the water distribution source with aid of a pump. Basically, they use a pump to deliver um, this amount of concentration of sodium fluoride. And the factors limiting usage are it needs to clean the gravel bed used for filtration. So whenever you are applying this or whenever you're supplying this to the water, there should be a filtration process. But if you're using the saturated system, one of the limitation is we have to clean the gravel bed every time. And the recommendations for this system is suitable for medium-sized town requiring less than 3.8 million liters per day. Whereas a dry feeder, the procedure which we do is sodium fluoride or silicon fluoride are the components which we use in the system. In the form of powder, it is introduced into a dissolving basin. So one of the limitations is care in handling fluoride and obstruction of pipe and compacting of fluoride while storage. So since it is in a powdered form, all these things has to be noted. And the recommendations are suitable for medium-sized towns requiring 3.8 million liters per day to 19 million liters per day. So as the system, so saturated feeder system is recommended to smaller towns, whereas dry feeder is something of a town which you can recommend for a medium-sized town. Whereas a solution feeder is a volumetric pump permitting the addition of given quantity of hydrofluosilicic acid in proportion to the amount of water treated. So the limitations are the equipment must be resistant to attack by hydrofluosilicic acid. So basic equipments which will not react with this acid has to be used in the system. Then necessitating construction in polyvinyl chloride or another plastic. And the recommendation is suitable for medium-sized and larger towns with a capacity. This is something which is bigger of capacity of more than 7.6 million liter per day. So this is something which is a bigger. So these are three systems which are basically used for water fluoridation. Then what is optimum level of fluoride? So you may get this as a Viva question or even as a short note. So the optimum concentration for fluoride in the water is in the range of zero point 0.7 to 1.2 parts per million. And this range effectively reduces, or it has been known to reduce, tooth decay with minimal chances to cause dental fluorosis. So how do you see, or how do you recommend, see whether what is the a desired recommendation or what is the optimum level of fluoride concentration in a particular area based on the temperature or their uh, weather. So Gallagher and Vermeulen came up with a formula to find out the ppm, the optimum concentration of fluoride in a particular area. That is, they came up with a formula that is ppm of fluoride. Fluoride concentration is equal to 0.34 by E. E is nothing but estimated daily water intake of children in ounce per lb of body weight. So E is basically calculated as minus 0.08 plus 0.0062 into T. T is nothing but mean maximum daily air temperature in degree Fahrenheit of the area. So they came up even with some recommendations and ranges for temperature in degree Celsius and the recommended ppm of fluoride in those areas with this temperature. If it is less than 18.3, the recommended ppm of fluoride is 1.1 to 1.3, whereas if the temperature ranges between 18.9 to 26.6, it can be zero point 0.8 to 1. Then if it's more than 26.7, 0.5 to zero point 0.7. So here what we can understand is as the temperature increases, the water ingestion, the systemic ingestion of the fluoride through drinking water increases, and as it increases, the recommended concentration of fluoride should be reduced. So as the temperature reduces, that means the water consumption will be less. That means the fluoride concentration has to be increased. So advantages of water fluoridation is large number of people are benefited. Consumption is regular and both systemic and topical effect. Least expensive and most effective method for delivering fluoride. Disadvantages are interfere with human rights, other modes are not considered, then common sources of water supply may not be present. So next under systemic fluoridation is nothing but a school water fluoridation. So this is a suitable alternative where community water fluoridation is not feasible. So this can be given to the growing children in schools. So the amount of fluoride added in school drinking water should be greater than normal because the children have to stay in school for a short time of the day and to compensate for the holidays and vacations. So in that condition, we will be slightly increasing the concentration of fluoride. because the exposure of fluoride to children will be less as we considered about the vacations and the time which they spend in the school. So the current recommendation regimen for school water fluoridation is by adding 4.5 times more fluoride than we compare to that of the normal water fluoridation. So it provides maximum cariostatic effect in developing teeth since children spend only 6 to 8 hours in school, and there have been several studies and which has already proven that it is best. There has been around 25 to 40% decrease in dental caries with this program. Some of the advantages are good results in reducing caries, minimal equipment required, not expensive at all. Then disadvantages are children do not receive the benefit until they go to school. So in areas where the children are not going to school, that means in poorer countries it is not a feasible method. Then the amount of water drunk cannot be regulated. So every child, the amount of water they drink, we can't regulate that. Then you have the salt fluoridation, which was introduced by Westby in 1955. Initially, the concentration of fluoride was around 90 milligram fluoride per kilogram, but has been recently made 200 to 350 milligram fluoride per kilogram. So all of these, the procedure of the salt fluoridation can be either by spraying concentration solution of sodium fluoride, or even you can use potassium chloride on salt on a conveyor belt, or by mixing with phosphate carrier salt and then adding to the main bulk. So this phosphate will react with the fluoride. Till now, salt fluoridation has been tried in Colombia, Hungary, Mexico, and Switzerland, with Switzerland being the oldest. So they have been using this fluoridated salt for a very long time. The advantages are fluoridated salt is safe, and theoretically, fluoridated salt prevents dental caries by both systemic as well as topical action. So no supervision of a setup or distribution system is required. So you just have to take a belt and just spray it all over, and you can supply. That's all. Then low cost, it depends on individual acceptance and rejection. So there will be some countries which might not accept it. So even individual acceptance is required. Disadvantages are no precise control over indicated consumption. So there will be individuals who will take more of salt. They might consume more salt, and some will not even add salt. Since salt intake varies greatly among people, so international efforts to reduce sodium uptake has been there. So there also there is a problem where if people are not allowed to take salt, if they are not recommending for the use of sodium uptake, then there is no use in adding fluoride to the salt. Fluoridated salt consumption is lowest when the need for fluoride is greatest in the early years of life. So that's what. Then there is this milk fluoridation, which was introduced by Ziegler in 1956. Then the concentration of fluoride was around 250 milligram milk bottle for fluoride concentration was added to around 0.625 milligrams. The compounds which were used in milk were, as milk fluoridation was calcium chloride, sodium chloride, disodium monofluorophosphate, then disodium silicofluoride. And there are other methods like dietary fluoride supplements like fluoridated milk, salt, sugar, citrus beverages, drops with vitamins, tablets with vitamins, and oral rinse supplements. So there have been so coming when you are learning about dietary fluoride supplements, you should know what is the age limit, what is the maximum concentration which is recommended. So from birth to 6 months, we actually don't recommend this. Is something which was given by the AAPD and AAP guidelines, where fluoride concentration and supplementations of the child. So from 6 months to 3 years of age, the concentration should be less than zero point 0.3 ppm fluoride. And once the child becomes 3 to 6 years, you can actually increase. If it is less than zero point 0.3 ppm fluoride, you have to give them 0.50 milligrams. Whereas if the concentration is a little more, if it's more than zero point 0.3 to zero point 0.6 ppm, then you can give a concentration of about 0.25 milligrams. And 6 years up to at least 16 years, if it's less than zero point 0.3 ppm, you can give them 1 milligram. If it is zero point 0.3 to zero point 0.6 ppm fluoride, you can give 0.50 milligram. And nobody recommends more than 0.6 ppm fluoride in diet. So that is with system fluorides. In the part 2 session, we will be covering with the topic of fluorides. Thank you.